Diabetic foot disease remains one of the most devastating complications of diabetes worldwide. It is a condition that does not just affect the feet, it affects families, finances, mobility, work, and sometimes the very identity of the patient. The question most patients fear is, at what point do doctors say, this leg cannot be saved anymore? This narrative explores that journey in full detail. How a foot ulcer starts, what causes it to worsen, what tests doctors run to determine the severity, and the exact medical circumstances that force healthcare teams to recommend amputation. For many diabetic patients, the foot problem does not begin with a dramatic injury. It often starts with something simple: an unnoticed blister, a small cut, a nail injury, stepping on a sharp object, or even friction from tight footwear. Because many diabetic patients have peripheral neuropathy, loss of sensation due to nerve damage, these wounds go unnoticed. Days turn into weeks. The wound deepens, bacteria enter, the skin becomes dark, and infection sets in. Blood flow decreases because diabetes has already damaged the arteries supplying the legs. A dangerous cycle begins. Poor blood flow, delayed healing, infection, tissue death, more blockage, gangrene. Not every diabetic foot ulcer leads to amputation. Many can be saved if caught early, but certain warning signs indicate that the foot is moving toward a critical stage where saving the limb becomes impossible. To understand when amputation becomes necessary, you must first understand why the ulcer refuses to heal. 3 major forces cause diabetic foot ulcers. 1. Neuropathy, loss of sensation. The nerves supplying the foot are damaged by long-term high blood sugar. The patient cannot feel pain, heat, pressure, or injury. They continue walking on a wound without knowing. Repeated pressure causes the wound to deepen. 2. Poor circulation. Peripheral arterial disease, PAD. Diabetes causes narrowing and hardening of arteries in the leg. Blood cannot adequately reach the foot. A wound without blood is like a fire without water. It continues spreading. 3. Infection bacteria enter the open wound. Infection spreads into deeper tissues, muscles, bones. Sometimes bacteria release toxins that kill tissue rapidly. Together, these 3 form the lethal combination that leads to amputation. A typical diabetic foot patient may finally come to the hospital when the wound has a foul smell. There is black tissue, gangrene. Pus is draining from the wound. The leg is swollen. The patient has fever or chills. The toes have turned dark or purple. The ulcer has exposed bone. At this stage, doctors already begin to evaluate whether the leg can be saved, but no decision is taken lightly. A full medical assessment is needed. Doctors order a series of investigations to answer one major question: is there enough blood supply to save the leg? If the answer is no, amputation becomes likely. Here are the tests and what they reveal. 1. Doppler ultrasound of arteries. A handheld device assesses blood flow in the arteries. If the Doppler signals are normal, circulation is adequate. If signals are weak or absent, major arterial blockage exists. This is the simplest and fastest test to know if blood is reaching the foot. 2. Ankle brachial index, ABI. ABI measures blood pressure in the ankle compared to the arm. ABI of 0.9 to 1.3. Normal 0.5 to 0.89. Moderate blockage, less than 0.5. Severe blockage, less than 0.3. Critical limb ischemia, limb in danger. Critical limb ischemia means the tissues are literally starving and may die. 3. CT angiography, CT angio. This is the most important test in diabetic foot evaluation. It shows a full 3D image of the blood vessels, reveals exact locations of blockages, shows the degree of narrowing, helps surgeons decide if the arteries can be reopened. Stented. CT angio answers the life-saving question: is there a path for blood to reach the leg? When the arteries are completely blocked and cannot be reopened, amputation becomes inevitable. 4. MRI or X-ray of the foot. These tests help detect bone infection, osteomyelitis, deep abscess gas in the tissues, sign of gangrene, damage to bones and joints. If the bone is severely infected beyond salvage, removing the foot may be the only way to stop the spread. 5. Swab culture or tissue culture. Doctors take samples from the wound to identify the exact bacteria causing infection, which antibiotics the bacteria are resistant to. Drug-resistant infections, like MRSA, increase the risk of amputation. 6. Blood tests. These include white blood cell count, blood sugar level, ESR, CRP, inflammation markers, kidney function. Extremely high infection markers indicate that the infection is spreading dangerously fast. Doctors use specific criteria before recommending amputation. These criteria are agreed upon globally in diabetic foot care. The leg is considered unsalvageable when 1. There is irreversible gangrene, black, dead tissue that cannot come back to life. Types include dry gangrene, wet gangrene, gas gangrene. If gangrene spreads above the ankle, amputation becomes life-saving. 2. Blood supply cannot be restored after CT angio or Doppler if it is confirmed that all major arteries are blocked. No bypass or stent is possible. No blood is reaching the foot. The tissue is already dead or dying. Keeping a dead leg can kill the patient. 3. Infection is spreading into the bloodstream. Sepsis. When infection from the foot begins to spread to the entire body, symptoms include fever, rapid heartbeat, low blood pressure, confusion, severe weakness. At this point, amputation is not a choice. It is mandatory to save the patient's life. 4. Extensive bone infection. If MRI or X-ray shows that the bones of the foot are completely infected and the infection has climbed up the leg, removing the infected part is the only way to stop the spread. 5. The foot has lost all function. A foot that cannot bear weight, has no sensation, no circulation, and is severely deformed becomes a continuous source of infection. Doctors may recommend amputation to prevent future life-threatening complications. 6. Severe pain due to critical ischemia. Some diabetic patients have unbearable pain even at rest because their tissues are starving for oxygen. When revascularization, blood flow restoration, is impossible, amputation becomes the only way to relieve the pain. Amputation levels depend on how far the disease has spread. Below-knee amputation, BKA, is done if the knee can be saved, blood supply above the ankle is good, infection is limited to the foot and lower leg. This is the preferred option because it allows better mobility with a prosthetic. Above-knee amputation, AKA, is done if infection has reached the knee, blood flow to the lower leg is completely lost, the tissue above the knee is compromised, severe sepsis is present. Above-knee amputations require more energy to walk with a prosthetic. Doctors sometimes recommend amputation quickly because delay kills. A diabetic foot with spreading infection can move from local infection, arrow bone infection, arrow bloodstream infection, arrow organ failure, arrow death. Within days, amputation often saves the patient, even if it costs the limb. Amputation cannot always be avoided. However, many cases can be avoided if patients come early. Diabetic foot ulcers can be prevented by daily foot inspection, strict blood sugar control, wearing proper footwear, avoiding walking barefoot, prompt treatment of small wounds, regular checkup for circulation problems, early antibiotic treatment, early debridement, removal of dead tissue. The single greatest factor that prevents amputation is early presentation to the hospital. Doctors often see the same sad pattern. A patient notices a wound. They think it's just a small cut. They apply toothpaste, herbs, honey, hot water, or spiritual oils. They hide it from family. They walk on the wound. They come only when the foot smells or turns black. By then, the choices are few. The medical team, surgeon, endocrinologist, vascular surgeon, infectious disease specialist, will only recommend amputation when the limb cannot be saved. Leaving the limb causes more harm. The infection threatens the patient's life. Blood supply restoration is impossible. Tissue death is irreversible. The goal is to save the life, not just the leg. A diabetic foot ulcer becomes a medical emergency when blood supply is critically low, infection is deep, or spreading gangrene is present. Bone is infected. The patient shows signs of sepsis, CT. Angio shows no salvageable arteries. Amputation is not a punishment. It is not the end of life. It is a life-saving intervention when all other options have failed. But the most powerful message is this: most amputations are preventable if diabetes is controlled and foot care is taken seriously.
Thank you for watching. If you find this kind of videos useful, hit the subscribe button for more.